to this.
Deitrich is going to be introducing the next speaker, Chris. When he waves his hand, you take off.
Is that all right? Can I just stay here? So I asked my friend John Rao to give us a quick overview of the issues involved in dental materials, that focusing on the non-metal restorative materials and bonding materials. I've only become aware of how big an issue this is over the last 5 or 6 years. And I know there was the Health Canada study, there was a review paper written on the plastics, and it shows in terms of the amount of plastic that we have in the mouth and the abrasion of it and the daily spilling of bisphenol A and phthalates and the other chemicals into the system. It's by a factor of 1,000 less than what we get with our daily nutrition. We get all these chemicals 1,000-fold more than what comes out of the teeth. And so we thought for a while we were safe. But just doing the kind of testing I do and doing the kind of follow-up with patients, I just have to say that we have been causing a lot of health problems in people by putting plastic and ceramics and whatever in their mouth. And the issue is by no means settled at all. We sort of left in midair. John here has been one of our most intellectual leaders in our field and has given this a lot of thought and done a lot of, he's on the phone every day and on the internet kind of looking at these issues, and I asked him to give us a little overview of what he has found, and we're going to try and limit it to these 15 minutes and then maybe a couple of minutes discussion. So some of the issues you may not be able to go deep into it, just kind of say what the issues are, because we won't be able to give you a solution, but more like raising the issues on where we need to look and keep going deeper.
Yeah. I have three cases that kind of illustrate a common denominator here. That is the importance of the complete polymerization of plastics. Plastics is what we have to use in the bread and butter of dentistry. And so the three cases have a common denominator about being the importance of trying to achieve a complete polymerization of these plastics. The implication being that I would like to get a discussion afterwards of how people are actually using samples to do their biocompatibility testing on patients. Now, I'm assuming now that the laboratory testing for biocompatibility, I personally don't have any credibility in. That's using the serum tests. For one reason, the serum tests, they're not actually testing the material that you're testing for. They're testing components, chemical components that have been used to make the composite or whatever they're testing. So any of the individual components, or for that matter, the composite that's uncured, in most cases is going to be toxic. Even the dental literature, uncured composites on histopathology or have a toxicity. So the implication is you should be actually testing something that is completely polymerized. So the last amalgam I took out was in 1980, and if you guys, the old guys going back in those early days of plastics, everybody knows there were lots of problems, and in my area I know there were at least 2 dentists that lost their licenses because they were putting in biocompatible materials, but the technology was not there and the materials didn't hold up and there was leakage and recurrent decay. And I was fortunate, back 17 years ago, I went to a lecture by Raymond Bertolotti, and that is what saved my ass in those early days. And the early research was by Fujiyama in Tokyo, or in Japan, and he was the person who actually introduced all that material to the United States. And back in those times, everybody was, for instance, in the dental literature, they were arguing about trying to keep the acid etching off the dentin because you were going to fry the pulp and all. And Fujiyama early on showed that it had no toxicity of phosphoric acid on dentin. But in those days, the Japanese academic community were non gratis in the United States professional literature. So let me just see if I could use this. How do you get the, next thing you have to.
It's this one forward.
Forward, okay, good. Okay, so this is a classic ad from a 1980s dental journal on photocure by Jay Morita. Now, Fujiyama is the main researcher that was the basis behind what we all is commonly used now as Panavia and the Clearfield, which is probably one of the most commonly used dental materials now. But back in 1980, it was a new thing and didn't have any credibility in the academic community whatsoever. But this is a classic ad that I really appreciate because it says, an interesting thing happens when in light cure dentin bonding agents when the light goes out. Absolutely nothing. So those early composites that were based on the Bernicore patents and all that were used, the light catalysts, if the light was not sufficient, you would not get complete polymerization. So Fujiyama was the first one to point out that the importance of doing a chemical set and not to rely on the light. So that's what saved my ass in the early days was I didn't have to rely on the light. Because, of course, now we have powerful lights. In fact, Gordon Christensen was in my town last week, and he spent a whole half a day talking about lights. And it's one of the points I'd like to make is that with this technique, it's irrelevant, the lights. I don't know. Everybody know about Bertolotti's? It's common, fairly common knowledge. Okay, so I won't dwell on the research. I have a sort of handout that has the references if you want to deal with it. This is.
Say next, and I'll do it.
Oh, I can do it here. Well, the important thing about. Let me go back one.
You can
Go back one. Well. That's not necessary. The important thing about the directed shrinkage is with the chemical set is, first of all, all plastics when they cure, they have a certain shrinkage to them. And it's going to shrink to the greatest bulk of material. And with the light, not only is it shrinking to the greatest bulk, but with the light, the activation of the cure is from the outside in. And so if you have an inadequate bond to the dentin, the shrinkage as it's cured actually is going to pull the material microscopically away from the dentin because it's curing from the outside in. With a dual cure or a chemical set, the shrinkage is toward the dentin according to the bulk. And of course, since then, everybody talks about hybrid layers and smear layers and all that, and it used to always kind of bother me, the idea of cementing in filth in this smear layer as a part of the bonding. So the importance that Fujiyama brought out was the importance of the etching and the use of a chemical set or dual cure for directing the shrinkage in increments toward the wastewater. Anyway, this is pretty elementary now, but in 1980 it was. The other thing I want to point out is you don't need a $10,000 light to do biocompatibility testing. That's one of the. And that's big business now, is selling lights, because most all the products on the market are light activated. And so, anyway. Here is a paper on progression of microleakage in restorations that use the smear layer as a part of the dentinal bonding agent. So we won't go. So this is the original product that was the basis of their Panavia and the original research, and I still use this today. This is a solely chemical set. It's the chlorophyll new bond, and then actually I also use this. This is previously it was called Gluma, and this is the copy of the Gluma, which is a HEMA priming agent that accelerates or the new chlorophyll new bond. Originally you didn't need to have that, but that's the latest. And then after that came the photo bond, because I guess the company saw that was where the market was going, was lights. So that was what that ad was for. Anyway, let's not dwell on it. Let's see here. Now, where do we go? Photobond is dual cured, yeah. And a lot of people use it, but I still use the original. For 15 years. I go to these meetings and I listen to all the new things, and that's what I'd like to get some feedback from you guys, what you're using. And I hear all this new stuff, but at my age, I'm wanting to simplify things, and I haven't found any reason to change yet. So. Okay, then after the new chlorophyll new bond, I had a regular bonding agent that's a chemical set with a dual cure catalyst, and I happen to use the generic Pentron material. Then after that, the original Bertollotti technique was to use chemical set. This is the Bisphenol 2B, and there's also a darker shade. And so I usually add a dab in every case of the A3.5 darker shade into the two, and then you can juggle the shades up and down that way, and it reduces your inventory considerably. I just use 3 tubes, plus the overlay. And the chemical set is, the setting time is just perfect on this. And since then, like Bertollotti is affiliated with another company, Danville, and they try to come out with a competing material. And generic also has a bond for core buildups and all. But the handling properties have never been as good as this original. The other products tend to incorporate air easily, or they're sticky, and it's delivered in a small micro syringe that's put out by De Novo Mix and Jet, is what they call it here. Okay. So, yeah, okay. Originally I used heliomolar, but I don't use that much anymore because it actually has very lousy handling properties. The best material I use now is called Palfique, or this generic simile. Palfique. Yeah, it's PAL. It's a Japanese product. PALF. It's listed in the PALFIQUE, something like that. Okay, I'll just go through quickly. That's the small syringe, and then this is all kind of basic things. But the thing I want to point out here is you alter it's easy to alter the shade in very few steps for the base layer, and then you can modify it as on the final surface. The final surface is a light cure, but it's only going through a small thickness, and so you can use any old low power unit. And then, of course, adjusting the occlusion is extremely important on plastics. Now, this is how I originally would biocompatibility test these things, is to make little tabs of the materials and put them in an autoclavable bag like this. And this is what I like to see what other people are doing, in that really you need, when you make the tabs to test, you need to have the bonding agent that you're going to use in conjunction with a particular overlay composite to test the whole thing at one time rather than individual components. And they all have to be cured. and you have to cure it in such a manner that you don't have an air-inhibited layer on the Tim Fraser wasn't here this year, but I found this is really an important product to use in marginal cases that are going to end up root canals. This is the copper phosphate cement with copalite as a... Anyway, I urge you to look into this if you're not already looking into this. Okay, now the next series of cases is using what's called in the generic trade acetal, which is a completely polymerized polymer. This came out of the space industry, and the important thing about it is it's completely polymerized in the factory, and that to use it, it has to be melted and then injected, just like you would inject cast a gold crown, except you're casting the acetal material. So this is a case of crowns and partials using all acetal. And the thing about acetal is it's so completely polymerized that nothing will, and it's inert, nothing will adhere to it. So to get any modifications on it, you have to do a mechanical surface tension treatment. So these are this is a case where there was a lot of gross decay, and the form and contour of the after the decay was removed is done with complete direct composites. So if you want to change the vertical or the profile, so I do all this in direct composite and establish the phonetics that you want to do in the direct composite, and then take a matrix that's a reference point. So this is at this point here. This is the point where the teeth have been just corrected with direct composites and based out before being prepped, and then you determine what the shading character is. So then the teeth. This is regular dentistry. Prep the teeth alternately, take the impressions of alternate teeth, then you maintain the reference positions of, and then temporaries are made according to the original matrix, and reference to the establishing the writing reflex as a heart. Dr. Bigelow mentioned that yesterday as the main reference for establishing right to left symmetry. And then that's transferred to models. And then the preps are waxed up in a traditional manner. And then it's flasked, because the wax is going to be boiled out and injected under pressure with the molten acetal material. That's what it comes out as after it's, and then the individual crowns are worked down. So, and this is, of course, one basic shade when you have at this point. So to modify the shade, you have to do a cutback, and bearing in mind that there's no chemical adhesion to this material, the overlay is established using a technique where microparticles of composite are sandblasted mechanically into the surface of the acetal, and then using a silane agent, a composite material is overlaid over that. And this happens to be Espy's Symphony, using first a clear layer, and then this case happened to also use an acetal partial denture. This is with the partial denture in place. Okay. All right. the latest company in doing that. Most of the acetal products that come from Italy. There's two, the Dental D and the Thermoflex material were actually Italian products, and currently there's a new company out of Portland, Oregon, and this is the latest way to make single crowns. Is actually instead of melting it in an injection machine, it's like a glue gun. If you want to learn more about this technique, this is a German technician who comes over frequently and has done a lot of work in Germany. This is in this country, some labs are calling it provisional temporary crowns, but in a lot of these type of patients, nothing is permanent. Everything is provisional. And so these crowns are long-term. This might be a good speaker for one of our meetings, maybe, if you wanted to get more into the technology of making these acetal crowns. Okay, this is a new plastic bite, thermoplastic material that's completely polymerized, but it's can be heated in a microwave, and it's a great material for taking bite records. The compatibility issue is, in my mind, we'll talk about it maybe later, is whether the most important thing is whether the patient can taste anything at all off of the sample that because the taste sense is a very sensitive in most people. So this is a case of overclosure. Just reestablish the vertical using a swallowing reflex. We don't have time to get into it, but the material, when you heat it in a microwave and manageable, it actually becomes clear, and then as it's cooled, it turns white. So in a lot of these cases, unless the patient has a lot of antalgic bracing and in muscle spasms, most people I can deprogram the proprioceptive feedback to the muscles just by having them bite on cotton rolls for a period of time. More severe patients may require.
We're going to stop.
Okay. That's what the flasking looks like. Let's see. That's the end. Okay. I have a little handout, and hopefully I can get a discussion later with each of you about what other people are using. And okay.
Thank you, John.
Yeah. So John is willing after the next little talk to meet with whoever's interested in these issues with you to establish like a little task force within our group to evaluate the materials issue. From my German experience, it's an absolute huge issue, and there's virtually no discussion going on amongst our dentists here on this issue. And yet we have so many environmentally ill patients, and most of you are not getting them well, thinking it must be something else that's causing this, and it's still the dental materials. Most of you in the group, I have to reprimand, are underestimating this plastic and bonding agents and the issues of the white stuff in the mouth. It's a huge issue that is destroying every day thousands of lives in the US alone, and the biological dentistry group should not be participating in this, but is fully participating in it. And so we need some people that take leadership in this issue, and right now it's really Sweden, Germany, Switzerland, also these countries that have gone ahead with actually looking at these issues in more conclusive ways and come up with solutions, many of which look old. Look like old and outdated. Would you hook this one up? Do you know how to do this? Okay, so I have the last talk. I guess hey Bill, I'm just going to introduce myself quickly.
Please do.
The first time I gave a lecture in front of a group of people was in this room here about 20 years ago when one of my teachers, Dr. Franz Hopfer, he was the main European neural therapy teacher, had a death in his family and called me in Santa Fe and said, Deitrich, could you give my talk? You've been with me long enough, you can do it. And in those days I said, sure. So I gave my first lecture here, and today it's a similar situation. One of my oldest teachers, Dr. Jochen Gleditsch, asked me if I could give his talk here. He's now in his early 80s, and he felt it was just a little bit too much for him to travel just for one lecture here, even though he was considering it. So he asked me a few days ago, really, to give his talk. It's the oral acupuncture is on the far right, if you click on that one. So Dr. Jochen Gleditsch, just very briefly, now I have to compress an hour and a half talk that I assumed I was going to have this morning into 15 minutes. So I hope I'm going to do him justice. So Dr. Gleditsch was an ENT physician, teaching at the university level, but also having a private practice. He was doing both, and was one of the early German acupuncturists. We had after the Second World War, many of the Germans, went to China and Japan to learn acupuncture. Because actually in the Third Reich, acupuncture became very popular. Because I don't know if Hitler was very much into yoga and meditation and vegetarian food and all those things that we think are, innocent. And so there was an introduction in Europe, to all these things. And then after the Second World War, Gleditsch was one of the first people to go over as a young man to China, study acupuncture, and brought much of that back. And then there was a very rapid development in him, and he developed the concepts of oral acupuncture, which are not Chinese. It's not a Chinese technique taught by Germans. He has been to China about 50 times since to teach the Chinese where the acupuncture points in the mouth are and what it is about. And it is the most powerful technique a dentist can use to, within the limits of your license, to affect distant parts of the body and heal distant parts of the body. Such things as hemorrhoids, knee pain, ankle pain, pelvic cysts, ovarian cysts, and fibroids in the uterus, spinal pain, and so forth. And Dr. Gleditsch was here to teach the technique 20 years ago, last time I think 10 years ago, and yet none of you have picked it up, as far as I'm informed, which is sad for me, because it's such a simple technique, and yet I know many of my friends here, none of them are doing it. And so I want to reintroduce you to it. This is not meant as a criticism, but there's something in this that is always the last lecture in this meeting, and always when the last lecture comes, hour and a half becomes 10 minutes, 15 minutes, which is not enough to stimulate you, but Gleditsch has now provided us with very good materials. He has a little DVD you can pop in your computer that shows the technique. I was going to do a demonstration here, but it's not going to be enough time. So I'm going to take you through the idea to hope to inspire you to learn the technique. I teach it in my neural therapy seminars again. I deleted that for a few years because there was no interest, but as of last year I have it again. So those of you who want to learn the technique, it takes about an hour. Really, it's that simple. It takes about an hour, and then you have to work for a while with your notes, which I hope most of you got the handout, that not Gleditsch's handout, but my handout that I made of his book that actually teaches you how to do it. It's about a 10-page handout that most of you have here. There weren't enough copies, so Carol Arana has a whole stack back there. Yeah. So this is with my text. It's got the 10 points of how to do oral acupuncture. You do it with a 3cc syringe, with a 27-gauge half-inch needle, and you can do everything that any acupuncturist can do anywhere in the world. You can do from the mouth with very, very minimum knowledge required. So let me take you through this. So I want to,
Just tell me.
Oh, this is not working. Okay, well, there's no point. Okay. Just kind of go. We're going to skip a couple of things initially here. I'm not going to. Okay. No. Let me wait for my sign. You have to go forward. So the reticular formation is important. It coordinates the links of the afferent nervous signals and the auricular points and the oral acupuncture points. So when you have pain messages or illness messages coming up, it's the reticular formation in the brainstem and in the brain, in the spinal cord and in the brainstem that organizes the communication with the skin points that are used in acupuncture and the incoming messages. Let's do the next one. So this is just, he's giving some examples here. This is the point, you put a little bleb of procaine in there and your patient stops gagging. You're doing dental procedures. It's an absolute must. If you only take one thing home from this weekend, when you do your nerve block back there, fine, but it doesn't stop the patient from gagging. But you put a little needle and put a bleb in the skin here, that stops the patient from gagging. Yeah, no question. I'm just, because I only have to the next one. Next one. Next, so this looks when you use an acupuncture needle. Okay, the acupuncture can also regulate the function of the oral mucous membrane. You can increase IgA. You can increase the mucin production, the composition of the saliva, which is a huge issue in tooth decay that I hear nobody talk about. It's the quality of the saliva that determines where your teeth are eaten up or not. It's not so much the bugs in the mouth. It's the protection that's in there. And acupuncture completely regulates it. It's been shown in a zillion studies that you can completely change the composition of saliva by doing, in this case, oral acupuncture. Next one. Okay, next one. Okay, there's two forms of acupuncture. There's the old form, the traditional Chinese meridian acupuncture, and then there is the new one that we call MAPS. That's the international terminology now. The somatotopic acupuncture. I'll show you what that is in a moment. Micro-acupoint system, MAPS. Let's go through this quickly. So the traditional acupuncture is meridian-oriented. The modern acupuncture, the microsystem, like e-acupuncture, is the one that's most known. The basic, most important thing is this, that in the microsystem acupuncture, the point only on the skin only lights up if there's pathology with the associated organ. In traditional acupuncture, the acupuncture points are always there. You can always find them. You don't know what it means. In a microsystem acupuncture, the point only lights up. It changes the electric conductance in the skin, and it becomes sensitive. And so it's a wonderful system because you can probe the points in whatever microsystem you work in the mouth, around the eyebrow. There's many of them. I'll show them in a moment. And the points that need to be treated light up. That means you don't have to know anything. You just have to know where the microsystem is. You palpate it. When it's tender, you put the needle in, inject it, and there's miracle after miracle happens with that. Next one. So here's the most common micro point systems. So the ear was the first one that was discovered by Nogier. Here again, it's not a Chinese invention. Here is a French discovery. Interesting, the history of ear acupuncture. Nogier was an art collector and had these paintings from France that showed a man kind of walking, and these are like 1,000-year-old pictures from Morocco. A man walking in with obvious back pain, and there was a series of pictures, and then it showed his ear, that a doctor came in and stuck a big needle in the ear, and then you see the patient smiling, walking out. He collected that and looked at that every day for years until it dawned to him, man, maybe this is the photographic depiction of actually a treatment. And so as soon as he realized that, sure enough, how God works, the next day a patient walks in like this with acute back pain, and Nogier said, well, let's try it, and stuck a needle in there, and the patient came in, thank you very much. And then that was the beginning of this whole development. And so in the ear container, you see it's like an embryo upside down with a head here. And then there's a new acupuncture developed in Germany that uses the front of the tibia, where every organ is represented here. Gleditsch found this. It's called ESIVO line. ESIVO stands for embryo contained in the whole organism. It is a holographic representation of the whole body projected on a small body part. And so like on this little stretch of the metacarpal bone of the little finger, we have a representation of the eye, the ear, the brain, the knee joint, the hip joint, and so forth. And you can just palpate it down, and wherever it's tender, you inject, and your knee pain is gone. It's beautiful and simple, and you don't need to know where the head is, and you just palpate it, because you don't know if the knee pain is there because you have a dental interference field or because you have a knee pain. And so by palpating here, you find the tender spot, you prick it, the knee pain goes away. You don't know, and then you look up, what did I actually inject? It's that way around, and say, I injected the third molar area, and so that must have been a third molar interference field. So it's that simple. And so there's these different ones, and the latest one to join the group is the oral system, the oral acupuncture, the ESIVO system in the mouth. The whole body is contained in the mouth, and you just need to know where the points are, test them and prick them, and that's it. To the next one. So let's keep going. Next one. Next one. Yeah. So let's wait until I give you the signal to go back to that last one. Yeah. So microsystem points represent and relate to the corresponding organs and their respective functions. We heard of Omura's microsystem. It's in the hand. He used Korean hand acupuncture as the model, and I modified that. Next one. So this is just the points, the typical points in the ear. Next one. Now, Gleditsch found that when you use two microsystems, for example, if you do oral acupuncture and inject it there, plus adding in an acupuncture point for treatment of the same thing, you use a microsystem in the ear and the mouth simultaneously, you triple your results. It's a synergistic effect. Or if you use body acupuncture or neural therapy plus oral acupuncture. Yeah? But you can just do one system alone. Next one. All microsystems are cybernetically interconnected. Therapy performed at one microsystem results in the distinguishing of analogous points of other microsystems. Yeah? For example, I mentioned the hand line. You find the point for the low back pain, yeah? And you go in the jaw, in the retromolar area as the point for low back pain. They're both tender. You inject one of them, the other one disappears. Yeah? Unless there's a point that you missed, which you often do, and then it will light up slightly next to it, and you inject that, and then it distinguishes the back pain. Next one. So oral acupuncture was basically, it's based on Dr. Vold's chart that all of you have seen in this course alone 15 times, so I'm not going to go there. Next one. The 5 elements in acupuncture are represented in the mouth. Next one. Next one. Okay, so in your handout, I actually translated some of the key things into English, so you don't have to learn German to know this. But I have some trouble with the anatomy, and your dentists have to help me, with it. So first of all, the water element, the kidney meridian, is represented by the first 4 teeth, and the acupuncture points are up here somewhere. I'll let you know in a moment where they exactly are. And then the liver gallbladder is the canine, and then the 2 premolar teeth is the large intestine and lung, and the posterior molars are stomach, spleen, and acupuncture, and then the wisdom tooth is the heart, small intestine meridian. What is missing, what was always missing, is the pericardium, the triple heater, which is actually found in the retromolar area in the back here. And so this is just a general orientation. You can look in your book. Let's get to the next one. So I'm going to, next one. This is that chart. I can't see it anymore. So next one. We have a beautiful chart, by the way, at my company that is actually corrected because there is a mistake of the crossing meridians in there. Important here, the retromolar area. Yeah, if you want to create kidney drainage, you inject the upper retromolar area. Yeah, that's most patients don't have a wisdom tooth. It's not where the wisdom tooth is, but where the area behind the wisdom tooth would be. You prick the area with a needle, and where it's tender, you inject. I do like 5-6 little pricks in the area, and I just blindly inject. And that immediately opens up the kidney. We had a lot of people, from other physicians that got DMPS without preparing the patient whatsoever. The patient started withholding urine. They got into a kidney failure. It takes me 30 seconds to fix that. I go in there, I palpate the area with a glove, boom, boom, boom. I put a few injections in there, and they can't wait until I'm out with the needle, which takes 10 seconds, to rush to the bathroom, and they pee out 2 liters of urine because the kidneys kick in there quickly. It's that simple.
About prostate.
Well, it's the same. It's the same. You just kind of, for own prostate hygiene, it's a nice thing to do yourself once a month. Just kind of palpate if it's tender, to just put a few blebs of protein in there.
Opening up a large prostate.
Well, same. It just will take a little. You have to do the kidney meridian points here in the front, both there, and the retromolar points for the kidneys. And it's beautiful. Next one. Okay, next one. Okay, so this is the lower jaw. They got that crossing of the meridians, which is not accurate. Next one. Next one. Okay, so here's the technique that we use. First of all, the points are sitting on this side. They're not sitting on the gum by the teeth. I get into the exact position. They sit on the cheek side. Yeah, they're not sitting on where the teeth are. They're sitting on the teeth side. And so you palpate it with the glove. Let's say in this case here, this is after the liver meridian. As you look at after the first premolar area, so it would be large intestine, colon. If somebody has constipation, this is this area. You palpate with the gloved finger. If it's tender, then he uses a blunt probe, and to find the exact point, and then you put a little mark in there so you don't forget. Then you take your syringe, go in that area, and pepper it with Procaine. With about 1/10 of a cc of Procaine, that's all you need. So it's not an issue of amount. The next one. Next one. Okay, so this picture here will tell you where the points are. Look at this one here. So just to be clear, this is the lip, and then this is the tooth. And I don't know what this is called in English. The deepest.
Vestibule.
You also call it the vestibule? Okay, so the acupuncture points are facing the tooth on the cheek side. And in general, well, not in general, there is a progression. Like in the front teeth, the acupuncture points are higher. They're sort of mid-body of the tooth. If you would stick a needle through the lip, through the acupuncture point, it would hit the tooth in the middle of the white part of the tooth. In the back, in the third molar area, it's in the vestibule. So the line migrates slightly down. So it's higher in the front and lower in the back. And take a glove, and you can just do this with your finger, and you can do it yourself. Why don't we just do it as an exercise? This kind of, take your right hand, not the left one that you use for other things. I lived in India for a few years. And so you go do this, you start in the front. It's fairly just below the lip, and do this. You squeeze quite hard and wiggle it, and then you go in this street, go down and go further down, and notice the tender spots. If you don't find the tender spots, you're not pushing hard enough. There's nobody in the room here I can visually see who doesn't have any medical problems. So, well, yeah, let's be honest about that. And so if you're not finding it, you're not pushing hard enough. And it's a little bit of a sustained pressure. When you first push it, you're not feeling the pain. You stay on the spot for a few seconds, and kind of the pain comes up like that. And then you know the area. And then you go with a little probe. I use a little glass rod that we have for our ART testing, and push on the point. When I find it, when the patient, that's it, I push a little harder so it leaves like a little mark there. And then I go with the syringe and go in there, put a little bleb, and that's it. Let's do the next one. I need to take care of the time here. Okay, I'm out of time basically. Okay, so this is how the technique looks like. He uses, of course, a dental syringe with a dental needle. I use a 3 cc syringe with a 27 gauge half-inch needle, whatever. It's not about the needle and not about what you put in there. It's about hitting the spot. You can also do dry needling in those points. Next one. Next one. Next one. Next one. So there's the so-called RAM points. That's the ramus ascendens of the mandible. This is the connection between the upper and the lower jaw back here. This is the holy grail. I could take now anybody with neck pain or headache or so, and can demonstrate that it's tender back here. And what I do with most shoulder pain, neck pain, low back pain or so, I just simply prick in 2 lines. I go up 1 line here and 1 line here with like 5, 6 little insertion, boom, 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 boom. On the other side, I tell the patient, take a deep breath and move your neck again. The neck pain is gone. It's that simple and it's that effective. Once you start doing it, you'll be completely amazed how easy it is. And you don't need to know anything. So this is the holy ground here for all orthopedic problems back here. There's anything, jaw problems, TMJ. How much money have your patients spent on getting their jaw pain out of the way? Now, for the jaw pain, you can fix that usually in the first visit or maybe 2 or 3. but no more. But the occlusion, the mechanics of that, that may take 5 years, fine, but the patient shouldn't be in pain for these 5 years waiting for the pain to go away. That's a mistake. Pain and structure are two separate things. You can have the most horrible structure and no pain, and you can have an almost perfect structure and pain. And to relieve the pain is this area back here. Let's do just the last few pictures. This is the probe again, where you kind of first with the finger, then with the probe, and then with the needle. Always in that sequence. Next one. Retromolar point is the big discovery of Gleditsch, because people, when he was working at the University of Munich, he started the so-called Munich model, where alternative medicine and conventional medicine were married together, and it's a very, very successful model. And he started it single-handedly, because he was a professor, he got the results, everybody wanted to learn from him, and he found a language with the microsystems and the SIVO points, which is like some international committees sort of that have agreed on that language, and it was enough to satisfy the conventional guys to incorporate it. And virtually, when I was visiting, there was virtually dozens of people rolling in with wheelchairs, and half of them are walking out and kind of was wondering what happened to them, because the treatment only takes like virtually half a minute. I mean, he's nice, he holds your hand, he smiles at you, he's kind or so, and then he kind of listens to you, and then he's okay, and then he puts boom, 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 and the patient doesn't even know what happened, and they're walking out, and it's like, okay, let's do the next one. So this is some of the retromolar points back here. You palpate them carefully. Next one. Next one. So this is the Holy Grail back here. So that there is this band, and this is the triangular fossa. I don't know what it's called in English. And the holy points are one line up here and one up here, where you hit every organ, every related joint, every related structure. Next one. Next one.
That's more Latin. That's more lingual than you.
Well, no, it depends on. There is an explanation actually that is in my handout. He's tracing specific problems here. So here's the things that he recommends for the, for the upper retromolar points. That's a holy grail for sinusitis. Do the upper retromolar point, and very often within 5 minutes the sinuses start draining. And this also for the lateral pterygoid muscle. When you have the, the forward and lateral movement of the jaw, when the patient starts quivering and they can't hold it, and everybody is then kind of reacting with 3 years of splint therapy. We do that. We inject the retromolar area in the upper jaw, and very often it immediately gives that neurological quiet that then gradually comes back within a week. To a lesser degree, you do it again. You may have to do it 3-4 times before the brain has learned a new trick. I have all the relationships are in your handout that you have, so you can look up. If somebody has elbow pain specifically, where you look in the jaw, which neighborhood, and then always you combine in the jaw always the retromolar areas plus the specific acupuncture points for that joint or organ. You always do 2 things. Next one. Let's just keep going. So that next one, I just want to see. So the point orientation or localization is performed by digital palpation, and then the exact localization with an instrument. You don't need to know anything about it. You just need to know where the vague areas are and palpate it. And you always do the four stretches of the acupuncture points. You always do the retromolar area, and you always do the RAM points, the connection between upper and lower jaw and the back. Those are the 3 areas. And then there is extraoral acupuncture points, which are exactly where the intraoral ones are. I like to use those because you can brush it with a needle on the outside, and patients say, "Oh yeah, that's a hot point." You stick a needle in, and your pulpitis is immediately gone. A few seconds, and the pulpitis is gone. Those of you who I asked 2 years ago here, like, how many of you are occasionally seeing that the teeth of the patient have become sensitive after you put your fillings in? Not a single arm went up. Not a single one when I asked 2 years ago. So I'm saying, I'm just like one of the few, I'm an MD, and I see the occasional patient that seen one of you guys who did develop like maybe 1 or maybe even 2 sensitive teeth. And that's what we do. We palpate out here on the level where the acupuncture points are, look for the sensitive points. I use acupuncture needles because it's quick and you can leave them there and do something else. But it's nice to inject them as well. Next one. So let's just kind of go through them now. Okay, he uses only 0.5% procaine. I use, it's important without vasoactive, vasorestrictive agents. We use 1% procaine without preservatives. That's been a standard in neural therapy. Next one. Next one. Next one. If you have pain on the left side of the body, he prefers to check the retromolar area on the opposite side. That's the most effective place. Palpate it, inject there, and will immediately release the much of the pain on that side. Next one.
Always the retromolar place, not the contralateral.
Well, the retromolar ones is a quick hit. If you just only have 5 seconds, you do the retromolar area. If you have half a minute, then you do the palpation of the point and inject those as well. Next one. Next one. Oh yeah, the franular points are important. Let's show it. The next picture. So here's a frenulum in the upper, I assume it's the upper jaw, and there's these points right here high up on the frenulum. Now, this is an acupuncture beginning of the governor meridian, which starts here and goes back down and ends near the asshole. And this is for all complaints near that region. If you have an anal fissure or hemorrhoids that hurt, I get once a year, I get like this wonderful hemorrhoid pain which makes you sing if you don't know what to do about it. And then you walk around, sort of for whatever, for half an hour. Some of you may have, I'm sure I'm the only one in the room, but I'm just speaking for the other 2 people in the room that may have had this. And what I do now, I just pull my procaine, draw my procaine up, inject here, and immediately the pain is gone. Immediately. And anal fissures, which can be really, really hardship for people, often end up with these cruel surgeries. You do like an injection here twice a week or so, maybe 3-4 times, and it's all gone. The opposite is on the lower frenulum. That's your trouble in the vaginal area, the pelvic area, prostate area, penis, premature ejaculation, all the kinds of things that we see, in the male and female GYN bladder area, cystitis, all those types of things. You inject the same points on the lower frenulum. Fantastic. If they're tender, you remember with the oral acupuncture, if it's not tender, the point isn't lighting up, it's not going to be responsive to therapy. Next one. Next one. Next one. Next one. Oh yeah. Now, the very point technique, the wonderful thing is this is the term now used internationally for Gleditsch's technique. He brushes the areas with the needle and sort of with the mild pressure, so like a sewing machine. So he palpates the point like this. He moves the needle on that mucous membrane or skin like this with very light pressure and feels to where it wants to slip in. And that's usually where the patient says, ouch, and that's where it sort of slips in. And Ed Arana was watching Gleditsch doing this, 18 years ago. So when he was here, and Ed says, oh, look, he's finding the very point. And then Gleditsch kind of lit up and says, oh, I'm going to call this the very point technique. And this term is now used in China, Japan, or so, everywhere in the world. It's called the very point technique. And I love that because Ed really coined the term, and it's now become in all the German textbooks in the universities or so. It's a very point technique. So it's, and even in Germany we use the word very point. Next one. A gentle dabbing along a suspected area within the injection, with the injection needle itself. This is what the very, you dab it, and then the patient says, yes, here, and there is a give in the tissue, and it goes in. This doesn't apply to the other acupuncture points, really just in the microsystems have that. In acupuncture points, often there's a resistance to stick a needle in. But in the very points, it's like almost like there's a funnel, so it's an energetic funnel. Like you go in the area, and you sort of fall into it. And that's the very point. That's Arana's very point. Next one. Yeah, this is the tender spot. There is a, we call it in trigger point therapy, how do we call it? Twitch response? Yeah. Yeah. Okay, next one. Okay, the extraoral points are the ones that I mentioned, exactly where the points are on the inside of the lip, they're on the outside of the skin here. For some of you, easier to do, but if you're a dentist and you feel your license allows you only to work inside the mouth, you do the ones inside the mouth. You have pretty much the same effect. Gleditsch is doing more and more with the extraoral points and less on the inside. And the reason, he told me, is because he often forgets his gloves. Let's do the next one. If there's one more. Okay, this is how it looks when you use an acupuncture needle. This would be like, in the area maybe of the canine or the one of the anterior teeth. So, the canine area, that would be, if you want to increase gallbladder drainage or liver drainage, or you have a gallbladder colic, is very, very effective. Or just simply if you have like a lot of gas and digestive problems after eating, I often palpate here and then do some acupressure in the area, and it just eases it immediately. Next one. Next one. Okay, so there is these groups of points in the mouth that you need to consider. The vestibular points, which are the ones you palpate on the lip. The retromolar points, the ram points, are the ones on the ascending ramus of the mandible. The frenular points, the rectum and vagina, and the extraoral points. And that's the system of oral acupuncture. In your handout, you have all the points. If you want to see it in action, come to the neural therapy seminar or any of the other seminars I do. I'm always happy to do a demonstration with any of these techniques. I know. Do you want to?
Lymphatic belt.
Yeah. The lymph belt. I left the lymph belt out, but the points are basically after each procedure you do in the head area, whether it's neural therapy or dentistry, you should inject the lymph belt point by Gleditsch, and it's a horizontal line below the clavicle in the front, and it's a horizontal line that crosses the spinous process of C7 across here. It's fantastic. You just flush out all the swelling and the post-surgical drool and all that. We don't have time to go into that. Thanks, guys. Bill, do you want to say a few finishing words here?
It has been a wonderful pleasure having each of you here. I hope that that has satisfied your needs. I hope that you are going home a little uncertain about some things, and that it challenges you to do all that you can do, because there's an unquenchable thirst for continuing education that we find in biological dentists, and God knows what it is that drives us, but I'm glad that it's being driven. Thank you.